All right, well, we are good to go. So, all right, man, let's kick this off. Craig Clemente, how are you, sir?
I'm doing well. How are you?
I am very good. I'm feel like Joe Biden. I can't get my phone in my pocket. There we go. This one was snapped.
Just leave it on the table.
Yeah,
man.
I should have done that. I turned it off, so I don't know why I have it in my pocket.
Yeah.
But anyways, man, hey, I appreciate you joining me. I think you might already have the record for this podcast for the longest distance traveled from Philadelphia.
Nailed
so
it.
kudos to you. Sorry about the travel in, though. You told me that story. It sounded like a nightmare.
Ended up in Mexican airspace for half an hour. I don't know why.
I logistically, looking at a map, I don't know how Philadelphia to Dallas ends up in Mexican airspace, but hey,
It shouldn't.
you're here. It shouldn't.
That's right.
Better late than never. But again, thanks for coming, man. I know you didn't travel just for this podcast, but feel very grateful that you were able to work this in your schedule.
Oh man, you were the main driver, and for the couple of people that I'm meeting with here, you guys were important too.
Okay,
I
yeah.
came here for Spencer.
Hey, I wasn't going to set you up to say that, but
Yeah,
I'm glad
man.
you did, man.
Yeah,
But anyway,
absolutely.
so Philly, the thing I don't know much about Philadelphia. I think I've traveled there once, but I feel like there's a kinship with people from Philly, kind of like with Texas. Like you guys have a similar, hey, I'm from Philly, like I'm from Texas, almost that like F you,
Yeah.
I'm from here mentality. Is that true, or is that a misperception?
I'm gonna narrow that focus a little bit. So I'm originally from New Jersey, and I have said this a million times. So we have the Northeast mentality, and that's really the I-95 corridor, right? Washington to like Boston, right?
Okay.
We all share a very similar pace of life and way about us. But Jersey, right? When I started working in Houston and I worked down here for 4 years, I realized, we're very proud to be from Jersey. Everybody kind of hates on us and armpit of America, all that fun stuff. But there is nobody more proud to be from them state than Texans.
Okay,
right?
all right,
And then
all right.
New Jersey's right behind that.
Okay.
There are different reasons, but New Jersey is definitely number two.
Okay. All right. Well, so I just felt like there's this like general kinship, and people always tell me this outside of Texas when they come here, they have a perception that we're all just like everything is Texas all the time and bigger and better. And I guess maybe just being inside it so long, I don't feel that way.
Oh, it's real.
But I can see how it's real.
It's real, man. Like when you get that dude that's got like the big beard and he has at least one Texas oriented tattoo and like you see him and you're like, man, that guy, it doesn't matter where you are. You could be in Alaska. You're like, that guy's from
That's
Texas.
the cliche Texas guy.
Yeah,
All right. Well, I don't
sunglasses on either on his eyes or like on his hat.
the
Yeah.
Oakleys probably.
100%.
Yeah, okay,
They might be backwards on the back of his hat, all that kind of stuff.
That's awesome. Well, hey, we can take it, man. I mean, if we were going to be this way and not be able to take a joke, then there's something wrong with that. But anyways,
Right.
thanks again for joining, man. I am very excited about this topic today. The dialysis problem is one that's I've become more aware of here recently with the whole Freakonomics podcast, as well as Dr. Bricker bringing it up in one of his episodes recently. But, even though we scheduled this kind of irrespective of that event, the timing seems like it's pretty pertinent to talk about this today. So I'm very eager to dive into that, especially how it pertains to self-funding. But I think before we do that, real quick, we started touching on who you are and your background. But if you don't mind bringing the folks up to speed with who Craig is personally and professionally.
Yeah,
please.
man. Let me also say that I think that I have the record for most distance traveled here and probably most time with 12 hours. But, your shout out during Self-Funded with Spencer was huge.
Oh, yes.
I love that,
Yes,
man. I just want to throw that out there.
Yeah.
But yeah, who am I? Oh, that's such a deep question.
Not philosophically, but you can just tell me your career.
No, yeah, no.
You can go into the
I'm a
film.
risk junkie, man. That's
Okay.
what I am. I started off my career in Wall Street. Came out of college with a degree in finance and all that fun stuff, economics actually, and finance as a secondary, and just said, hey, I'm going to go to Wall Street, make millions of dollars, and just go that route. So that's always been in my blood. My father is in this industry, and so I worked for him from the time I was 14. I was working at like a reinsurance MGU. Getting groomed, didn't know that was happening. I don't think that was purposeful in any way, shape, or form. But, I ended up kind of working all around the different departments at a reinsurance MGU. So that was really kind of cool. Learned managed care there. Said that's not what I want to do at all. And then went into the Wall Street thing. Realized that.
Were you actually on Wall Street at the time? You working?
Yeah,
Okay, awesome.
we were on Gold, but yeah,
Okay.
I was down in that part of the city.
Okay,
Yeah.
all right.
So lived in Jersey City, took the PATH train over, sweat dripping off you. I worked in a really old school shop where we had to wear white shirts, ties every day. Your dress down day on Friday was not a white shirt.
Okay.
Yeah. So
Still a tie though, right?
still tie.
Oh, man.
Yeah. It was very old school. Anyway, So I think the common denominator that's always been of interest to me is risk, right? And risk is an understanding, how to allocate funds the right way and how to do things. And that's always been something that I've been keenly interested in. And that's been the constant in my career path. And so I've been working now for specialty care management since 2008. So it's been a long time. I'm now the president and COO. I've been the COO title for a while, but now I'm president as well as of the last year and a half. And so that's been cool, man. And we've had a great go at it. And I've just been, it's so fun to be able to be in this space. It's such a fun time to be in this space. And so that's me in a nutshell, I guess.
Well, can I ask, was there a breaking point with the finance world that you're just like, I can't do this anymore? Or was it more attractiveness just doing something different instead?
Yeah, I gave myself 2 years. I walked in, I was in a blue shirt. It was like a Tuesday, and my boss is like, oh, somebody's quitting today. I was like, yeah, I gave myself 2 years. And, I looked around on what to do there, and I realized, hey, that self-funded risk market's one that I realized, I said, I'll go back into that for a little bit. Did that, realized I had a huge wealth of knowledge about it and also a passion for it, which I didn't realize I had prior to. And so sort of happy accident, ended up sticking around. And here we are today. So that was really fun. I didn't realize until I understood the passion that I had for it.
Well, I think it's actually funny. I would echo that same thing. I didn't know I had a passion for this until it got introduced to me. And the more I learned and the further I got along, the more I realized, I actually enjoy this. People don't understand why you would get that interested in stop loss or why you would get that interested in self-funding. It's just, for whatever reason, I can't tell you. I find this stuff fascinating, and I try to make it present it in a way that's interesting, right? And so cool, however much we can make it cool,
sexy,
but sexy, very sexy. But I just feel like, to me, I have that level of passion. You obviously speak to it as well, and so just whatever level that we can advocate for the space and talk about different cool solutions and new innovation, I think it's fun. I actually enjoy these conversations, whether or not it leads to any sort of audience or 50 people at a time listening to an episode. It doesn't bother me,
So one thing that somebody can take away from this podcast, if they take nothing else away, if you want to make this sexy at the Thanksgiving dinner table, here's how you do it. You're not in insurance, you're in risk.
Yes.
Yeah, that makes it so much sexier.
Well, yeah.
When you say you're in health risk and not health insurance, everybody just is so boring.
Yeah. Well, they think, you're selling life insurance to grandmas, right?
That's exactly what everybody thinks.
Yeah. Yep. So, let's getting back on topic though. Dialysis. So that's going to be the general topic today, but we're going to talk about problem, where we are in the marketplace today in the United States, defining that problem, as well as talking about what solutions out there, especially specialty care management. But before we do that, can you tell me, for the uninitiated, what dialysis is and why it's a treatment methodology?
Yeah. So, and specifically, just to narrow that even more, so we're talking about the risk associated with outpatient dialysis, right? So the difference between outpatient and inpatient is inpatient, obviously done in a hospital setting. Typically, it's an acute situation where it could be from a car accident or whatever it might be, but it's finite, right? Okay. It's not chronic. It's not ongoing. When folks end up on chronic, they have chronic kidney disease, end up with end-stage renal disease, and ultimately end up on dialysis. And really, the only outcomes that take them off of dialysis are transplant and death. Those are the two ways that you get off of dialysis, right? Very, very few people go on dialysis and then it works and you restore kidney function. That doesn't really happen. So why it happens is, I'm not a clinician, so I won't get into all the whys, but what it comes from is some really big buckets, right? It comes from things like diabetics. It comes from things like, heart disease and high blood pressure, et cetera. So really common things. It's often thought of as this kind of, that won't happen to me sort of scenario, but it's really very tangible.
Yeah. Well, and so you said it was usually as a result of ESRD, right? End-stage renal disease is when this, not the acute version, but the chronic version.
Right.
This is used as a treatment for that. So end-stage renal not in a non-clinical way. What is that? That's just your kidneys are starting to fail for something. Yeah.
They have failed.
They
right?
have failed.
Both your kidneys are failed, so you can obviously live life perfectly fine with one functioning kidney. People give one away often.
Yes.
But if they both fail, it's a vital organ. You need to have them working. So what happens is ultimately you need to go and you have to have a machine and you have to have drugs and everything to be able to have your body function the way it needs to do. So the filtering that your kidneys do, you have to have that done, on a machine. So dialysis is really, it's performing that function for your body. And however you choose to do that, whether it's 7 days a week at home or it's 3 days a week in the center, whether it's a big machine or it's done, like I said, in the home setting, either way, it's that filtering being done, for you.
Well, okay. So that's what dialysis is. Now, let's get into, how it's become a problem, how prevalent, like I mentioned earlier, Dr. Bricker, if you guys haven't seen the episode where Dr. Bricker's on, this guy is an absolute machine in terms of research and bringing, problems and solutions in these really nice little 7 to 10 minute buckets of video. And so he dedicated an episode specifically to this. On the heels of him listening to the Freakonomics podcast recently, which they dedicated an entire podcast, for some reason, right? Like people go, why dialysis or why dialysis management? Why is that big of a problem? It's for whatever reason, it's kind of becoming to the forefront. And Freakonomics, being one of the biggest podcasts in the world, decided it was a problem worth talking about. And one of the things that that stuck with me in that podcast is that about 500,000 people at any given moment in the U.S. are on dialysis. Was that number accurate, or is that close? Okay.
Yeah, it's like I said, it's thought of as this kind of thing that won't happen, but it's there, right? Like the numbers are there and the numbers are growing, and there's a lot of reasons for that, right? Some of it's the aging population, some of it's the shifting demographics racially. There's a lot of different reasons for that, and I'm not an actuary, so I won't get into all of those, but it's suffice to say that it's becoming a more prevalent condition, so the incidence rate is going down, which is a bad thing, right? So it's becoming more prevalent.
Okay.
At the same time, the costs are increasing almost exponentially, right? Maybe that's a little bit of an exaggeration, but the costs are increasing at such a rapid rate, and then you mix in some of the other dynamics that we'll talk about here, that's where it's a perfect storm of why this is such a high variability risk, and why stop loss worries about it so much, and why employer plans worry about it so much, and why we need to make sure that solution is married around managing all of that, the entire continuum of risk, and not just, hey, cost containment, first dollar, what am I getting off of bill charges?
Yeah, and so give me some context. So 500,000, sounds like a lot, but obviously the United States has 325 million people or whatever the number is today.
Right.
But that's 500,000 out of the entire population. But realistically, when we're talking self-funded and we're talking employer, stop loss, these are on larger employers, but employers that we're not throwing children in the mix. We're not throwing babies in the mix of that total population. So it's probably a higher prevalence within the subset of the population that we're talking about. So give me some more context on what that number actually looks like.
Yeah. So the generally used number. So if you're a broker advisor out there, you're probably hearing numbers like 1 in every 2,000 people end up on dialysis. And if you have, if you're working in the self-funded small group space, or even small mid-size, group space where you're at, 50 to 500, which is a pretty sweet spot for self-funding, right? And you're looking at, and that's who you represent, you're saying, that's not really a huge risk for me, right? Like that's not something that's going to happen to me. To make it tangible, it's 1 in 2,000. That includes all the people in this country, and that's really not what we're interested in. We want to narrow it down to, okay, what's your risk within the adult working population, demographics aside? So that number becomes 1 in 7. Okay. 1 in 7 of the people that are on your plan are at risk. They don't know it. You don't know it. Your data vendor might not know it, but it's there, right?
Okay.
And so to kind of narrow the focus on that even a little bit more, that's including all the healthy people on your plan.
Okay.
Before I talked about the 3 big buckets that it comes from. Number 1 by far is diabetics, right? So if you have diabetics on your plan, you have dialysis. It's there. It's going to happen. It's not to be overly cliche, right?
It's not if, it's when.
Not if, it's when, right? Yeah. And but it holds true here.
Yeah.
And so when we look at those 3 big buckets, ideally, we look at diabetics, we look at heart disease, and we look at high blood pressure. 1 in 3 of those folks is going to end up on dialysis. That's 33% of the folks that are on your plan that are going to have that That's their path. That's where they're headed.
Okay.
So you can manage away from that potentially with good case management, specific specialty case management, of course. Or if you just kind of let them go, 1 in 3 of them is going to end up on dialysis,
Okay.
and that's going to hit.
Well, and so, I mean, obviously we're talking about folks that are further down the line, right? Like this disease, what do you say, the progress of it has got to the point where the dialysis is a need. But is there conditions or symptoms or things to look out for that might prevent us from ever getting to that point? Because I don't want to just talk about, oh, it's already happened and here's the solution once it's happened. Obviously, there's things that we can look out for early enough to prevent it, right?
Oh, yeah. No, I think so. We talk about this as a risk management solution, right? And again, I kind of said before, cost containment, great cost containment is a huge part of any risk management solution. You need to be able to contain the $1 cost in order to have an effective product, quite frankly. But yeah, identification, and a lot of people are really good at this part, right?
Okay.
Identification of emerging risk. Oh, I found them, right? Mm-hmm. I found them, kind of know they exist. Honestly, though, from a patient perspective, from a member perspective, most of these people that end up on dialysis, it's a surprise when they end up on dialysis.
Really?
It shouldn't be, but most of them don't know. 1 out of every 2 people that are on dialysis had no idea until the day their doctor said, all right, you have end-stage renal disease. Okay, what does that mean? It means you're going to have to go on dialysis to survive.
Okay.
And they don't even know that. And of course, their plan doesn't know that, or they've invested in analytics and they've reviewed their claims and they know that these folks are there, and maybe they're managing them a little bit, maybe they're not managing them at all, but they're not necessarily looking at all the right things. So to proactively manage this is certainly the right way to go about managing this risk element, and chronic kidney disease in specific. But just identifying where those smoking guns lie, that's interesting, but what's the action item around that to be able to manage it? So look, some of them are going to end up on dialysis no matter what, regardless. And it's at that point though, it's can you manage them into an optimal transition, both as a human being and an employee, so they're productive, right? We all want a productive employee, and also from a cost perspective, right? So you want to make sure, and that's not steering or because I can negotiate the right rate or any of that. It's just so that you have built in to your foundation, into your plan infrastructure, the most effective way to manage this risk element.
Okay. And what, we're talking about the incidence and the prevalence, right, of this. What about the cost? I think the cost is probably the more shocking aspect to me. So tell me what the range of, we'll talk billed plus paid charges, because we always have to talk that in this space, but give me sort of an idea of what dollar amounts we're talking about.
Yeah. And I'll say this too. I think that a really important distinction to make is that everybody looks at cost, like you just said, and said, cost is the problem. Cost is the byproduct of the problem. The problem is build charges, right? And build charges are completely arbitrary. In this space, they are the trend on outpatient dialysis build charges is like 17.5% year-over-year compounding, whereas normal medical trend that we use in the stop loss market, et cetera, is probably 8%. That's pretty well accepted, right? 8%. So we're over doubling, the trend on that. And so I think that's a really important, piece to understand and kind of get your grasp around. And then as far as the cost, what the average costs look at. So listen, this is very micro from a geographic perspective. It's very micro, so it's very regional. But just national numbers, the average build charges on this are around $870,000.
Oh, wow.
So then if you start applying like your average discount across the board is somewhere around 40%. So you're looking at around a $500,000 average build charge. Average paid amount for this, regardless of solution, right? And so that's kind of your average.
Obviously that's a broad brush to paint with, because you said it's so geographically specific, and even just the actual facility, I presume that there's wide variance, which I think maybe we can speak on more as part of that problem. But I remember in the stop loss world, we would, the company I work for, Sun Life, would always do these annual claims, high cost claims reports, and they would look at incidence as well as severity, and end-stage renal disease was almost always at the top. I think, was it leukemia and other types of cancer were always 1 and 2, and then ESRD was somewhere around that 3rd or 4th or 5th bucket. And I think even at the time, I didn't have as much insight as to why that was such a problem or why that was always the case. But when you throw out numbers like that and you talk about how frequent it is just nationally, but how high of a likelihood on a self-funded plan or any plan that you're going to have somebody all of a sudden you get hit with $1 million or $2 million of billed charges out of the blue, and you don't know it's coming. That's an insane amount of money, you know. So how do we get to this point where it's not only so prevalent, but it's also so expensive as well? I mean, I don't think that's an accident, right? Or at least it wasn't one specific thing, but it's probably a series of things that have led us down this path.
Yeah, and to your point, right, on that Sun Life, pardon me, on that Sun Life report, on that hit parade, it's always like number 3.
Okay.
It's always, you know, I think I've seen it as high as 2 and as low as 4. But to your point, it's somewhere between 5 and 8% of their total. And it's
consistent year after year as well. It's not like that was just a blip on the radar. It is always up there at the top.
Always.
Yep.
Yeah, every single year over year, it's always on the top 3 or 4 of the hit parade. And so, yeah, I mean, that's really validation for what the problem is, right? And we sort of defined that out earlier. But I think the perfect storm that's happened here is we talked about the incidence rate going down and what's going up. But I guess, to not be overly, cliche again, but like what happened is really the dynamic started changing. There was a huge shift in the early 2000s, but the dynamic really started changing in like the 2009 when the ISA was passed. And what ended up happening is, with really well-intentioned parts, right? So the removal of lifetime maximums and then some of the other stuff that was in there, what it ended up doing is it created a situation where providers can essentially charge in bill charges whatever they want. There's a check, it's signed at the bottom left-hand corner or right-hand corner, I'm sorry. It's signed, and they're left to fill in whatever they want to do. This market happens to be, you mentioned the Freakonomics thing, happens to be a duopoly, essentially, right? So it's DaVita and Fresenius, and they own about somewhere between 80 to 85% of the total market, continuing to grow that. That's part of the market dynamic that continues to increase billed charges. Again, that being the risk, that being the problem, and the byproduct being the cost. So it's no coincidence either. And I think if let's say you're a broker consultant out there and you're thinking about this, we've personally, I've been involved in several instances where all of a sudden a network, a BUCA or otherwise, will come up with an incredible increase in their total discount that they can find, where it's like, oh, we only had a 30% discount. Now all of a sudden we're on the table, SEM, we have a proposal in there. There's some revenue to be, lost on their side. And then I go, oh, you know what? We can give you a 60% discount on that. And I'm like, well, if that was me, my first question would be like, well, where was that earlier? Yeah, right? Like, how come this is just coming out now because I put something in front of you? But so that dynamic has changed quite a bit too. The networks have adjusted, and so they've adjusted to have some much more significant discounts on outpatient dialysis. It still leaves an incredible variable, and it's still a super high dollar claim. So when you marry that variability of bill charges and ultimately like the discount off of them, and the high dollar nature of outpatient dialysis claims cost, that's why they end up number 3 every single year on that hit parade, and why it's so expensive.
Well, and one of the things that, I found interesting on that podcast was that, this is the only really situation, the only type of procedure that's in a sort of a Medicare for all, right? There is an element of this that's covered in the public space as well as the private space, and the dynamics of, the competing for business in that space I found pretty fascinating. So can you kind of give some of the history of that and what some of the rules are around the public version of that versus what private sector is covering?
Yeah, sure. And this is where there's some like really nuancey details I won't get into.
Yeah, we can keep it as high level. Yeah, for sure.
So, but I think it's important to understand there's plan and then there's member, right? Or patient, if you will. So there's plan and there's member, and there's applicability to both of them. So to your point, with it being sort of the one version of Medicare for all, if you will, that part of it is the Medicare Secondary Payer Act. That was passed in 1972, and basically it says, regardless of your age or any other parameters, if you have a diagnosis of end-stage renal disease and you are on dialysis as a procedure, you have the right to enroll in Medicare. Okay. Period. Right? Like, so the triggering event is actually your first dialysis treatment, where at that point you can enroll in Medicare.
And there's a period of time though, right, that it has to be covered. If there is primary care in the private sector of insurance, it'll cover it up to what is it, 30 months? Did I remember that correctly?
30 or 33, depending, mostly 33.
Okay.
And it's funny because one of the few things that like the Obama and Trump administration agreed on.
Imagine that.
Imagine that. And I don't know a lot about Biden's thoughts on this, but I'm sure he's in lockstep with this, is what they're looking to do is expand that coordination and benefits period to 42 months. So add an additional 9 months. What that does to our market is increases the amount of time that the employer-sponsored health plan is on the hook for paying that as a primary liability, right?
Okay.
So they're shifting it back to the private sector to take the burden off of Medicare, and that's what they're going to look to do. So that's even,
and that's where you see all the variability in bill charges and payment rates and those sorts of things is in the private sector piece of it, correct?
Yeah. So we'll use DaVita, right? DaVita, because they were under oath and I know these numbers. DaVita, 94% of their total claims are paid at CMS rates, so Medicare and Medicaid, right? So what does that mean that they're doing? As an organization, they're a publicly traded company. Warren Buffett's their largest individual investor. He's a pretty smart guy. He does a good job in his investments. And so what they're looking to do, like any business, is maximize their earning potential for the period that they can. Right now, that's 33 months long. Might be 42 months long. During that, they're just looking to maximize their earnings per share for their shareholders during that period of time. That's what we are here to kind of combat and fight against, is that dynamic where they say, okay, like I said, that's a blank check. We can fill it in and we can increase our earnings per share for our investors and we can, have good quarterly, reporting.
Yeah. Yeah. Then it kind of shocked me. And I think anybody that listened to the podcast on Freakonomics would walk away going, man, this feels a little bit dirty. This feels a little bit like there's, they mentioned a couple times the word collusion, but didn't want to legally define it as such. They mentioned duopoly. And obviously we don't want to get too much in the weeds there, but it did feel like there's a lot of taking advantage of the current rules and the gamesmanship, playing within the rules that are set, of course, but the rules seem to advantage certain folks and as well as incentivize maybe some of the wrong payment methodology and those sorts of things. And I err on the side of let's not get too biased about the process, but just present the problem. Now let's, we've laid that out there. It's a very clear problem. Some of the numbers you hear about in terms of the overall spend is insane. The Medicare budget and the overall GDP number is something like 1% of the federal budget, I think is what they said. It's a crazy amount of money. So we know the problem. Mm-hmm. What do we do to fix it, right? Let's start talking about how we can solve it. And I think one of the things I want to ask you about is the case management around dialysis. Let's start there. What does that mean to implement case management? Yeah,
so as you're well aware, there's a huge emphasis on analytics, right? on understanding what's happening within your population through claims data. A lot of folks are doing a really great job at that, right? And a lot of people out there selling that in my space, not in my space, right? So it's certainly something that people are emphasizing. So I used interesting. I'll just say this. Interesting to actionable, though, is really the idea here. Mm-hmm. And actionable in the right way, in the way that's going to be impactful. So for us, from my perspective, like the right way to do that is identify emerging risks, right? And identify where that population is, get them into effective, specialty case management, in this case for CKD, for chronic kidney disease case management. Have the right people involved in that program, build solution around that so that there's great utilization of the program. And that way, look, that's not going to make sure that all those folks don't go off onto dialysis. Some of them are just, I hate to say this, like predisposed. They're going to genetically end up, on dialysis regardless. But it's managing them appropriately. Again, from an employer perspective, make sure you have healthy as possible, functional and employees that are going to be productive, right? And we want to do that. And from a clinical and human perspective, just making sure that they are doing all of the things, whether it's dietary or whatever it might be, making sure that they're doing all the right things in their day-to-day lives as best they can and as best as we can help them to make sure that they are doing whatever possible to avoid the outcome of ending up on dialysis. And then from a plan perspective, having the net at the end of the stick, right? So like when somebody does end up on dialysis, you have a solution in place to manage that cost.
Well, yeah, I would say presumably, obviously, the primary intent would be always to prevent that from becoming the issue, right?
No doubt.
Prevent dialysis from becoming necessary. But if and when it is, right, there's probably a proper transition. We're never making decisions, self-funded employers are never making decisions in a financial vacuum where they're only thinking about cost. And you mentioned a couple of times, the outcome itself, how that member is being treated. Are they still, is it possible for them to still be productive employees as well? But talk to me about now that kind of transition that net that you just described? Okay, now we need it. Now dialysis is necessary. Where does specialty care management, SEM, where do you guys come in to sort of help with that transition?
Yeah. So one of the things that we've always, like our core value and our core competency is around risk management and risk mitigation. And again, cost containment being a huge part of that. But from my perspective, and that's been consistent from us. We've been around since 2002. And from us, that's always been our way about things. It's kind of managing the entire risk, not just first dollar, maximizing first dollar benefit, but creating something that creates value to both the employer, the customer, right, and their membership. That's really important. So focus on the customer and also with a center kind of fulcrum around the patient, right? And so for us, it's really about how it's best to do that. And we think that in order to do the proper risk management tool and put in risk management strategy in place, you need to have predictable risk. Predictable risk is something that everybody's striving for, right, in all things. But certainly when we're talking about something that's high dollar, high volatility, and catastrophic in nature, both, I guess, clinically, obviously, but also from a claims perspective. And so we want to make sure that what we've done is we build a foundation, and we build within the plan infrastructure the right way of dealing with the risk of outpatient dialysis as a claims cost. Okay. And then making sure that what you're doing there is, and then you're building solution and capability around that to enhance the member experience as well. So all of that can be done at the same time. So you're maximizing the financial component. And so, hey, listen, sometimes employers are interested in just the finances of it, right? And sometimes, more often than not, they're more paternal about it, and they want to make sure they're taking care of their membership as well. And the point is that we can kind of fit that bill no matter what happens.
Well, yeah, and you mentioned the predictability, right? I think that's an important point. I remember in the stop loss world, a lot of lasers would be around a dialysis patient or ESRD if you were to use that. Because you don't know exactly how much it's going to be, or it looks like this member might end up with that as a result. We know the range, so we're going to put a laser on this because we really don't know exactly where they're going to go and when it's going to happen. But you're introducing, like you said, a predictability component to the cost. So how does that work? How do you make it more predictable?
Yeah, so we really, this is a huge shift in what we've done over the past couple of years. Again, predictable risk is really the best way to make sure that when you have a solution in place, and we can do this obviously when there is an active risk element within the plan, meaning there's a patient on dialysis, or preemptively and proactively. And I think that's a really key part of this, right? Just doing that proactive risk management up front so that you're ready for it when it does happen. But what SEM does specifically, and one of the things that's really unique about what we do is we looked at the market and said, all right, this whole percentage of savings model, that's kind of the way of the past, right? And it also acts as a function of, you're still a function of those billed charges. Cap, no cap, it doesn't matter. You're still going to have variability, and you're going to be based on, hey, what ultimately did they charge $2 million in billed charges or $500,000 in billed charges, right? And we wanted to remove ourselves from that problem, right? So what we did is we started to, we developed with our partner, who's Windsor Strategy Partners, an underwriting model. So we have a Windsor model. We underwrite each thing. It's a cost up approach rather than a bill charges down approach, and it's pure cost. It's comprehensive, and we call it a case rate. So what that does is it gives the employer plan a budget line item. They have an exact, predictable, to the penny number that they can say, okay, that's what John Doe's dialysis is cost me every month, as long as he's active on the plan and receiving dialysis, right? Primary on the plan and receiving dialysis. And from a stop loss perspective, again, first dollar being super important, but we want to manage the full comprehensive nature of that risk from $1 to the final dollar claim payment. Because at the end of the day, most self-funded, a lot of self-funded, at least where we see stuff, right, in that small and mid-sized market, you're going to have this is going to breach your spec, right? And we want to make sure that that you're managing that most effectively, so that it's not only maximizing your benefit for $1, but it's also maximizing your year-over-year predictability, so that hey, I've got this taken care of. And if the stop loss market knows what's going to happen, they know exactly how claims are going to work each and every single month. You, me, and my 9-year-old son, we can all underwrite to a predictive cost. Right?
Well, that's why I was thinking that they would love this, right? Because it's one thing, most of your dollars on the spec portion of your contract are going towards the unpredictable nature of the risk. Because they have claims and they have history. Hopefully, if the group's big enough, they have a general sense of what the risk profile of this group is. But nobody knows for sure if and when this might happen. If you can put a set dollar amount every single year, carriers love to carve out a laser and say that's off my plan until it gets to 400,000. Great, they've partitioned that risk to know exactly where that's going to fall. But you're giving them an alternate solution that says, hey, we know to the penny what this is going to cost, as well as it's going to be a reduced version of what it typically costs in the normal world. So, you and I were joking about this earlier, win, win, win. That seems, overused phrase, but it is, right? So you've done a service to the stop loss carrier, you've done a service to the employer, and you've, presumably you guys are doing a great service to the member as well. So nobody really loses in that equation. And I love the fact that there is, you're reducing some of the volatility from the equation, which I think, is an easy sell for most people. Yeah. So logistically though, let's talk about, a little bit of the technicalities. How do you implement this? What does it look like to put this in place? What are the things that a group needs to think about?
Yeah, I think first and foremost is I think the biggest thing that we get asked a lot is, okay, so, do I have to go to a specific place? Are you negotiating all these? We're not negotiating, right? So I think if I could have somebody walk away from this with one other thing other than the New Jersey piece and the Texas thing, is that this is a space where it is high dollar and it is high volatility, to your point, right? And so what we want to make sure that we're doing is building the foundation within the plan and making the right assessment so that when this does hit, you are covered. The way that we go about that, so we're not negotiating with providers, right? So it's plan document based, and it's really the assessment of 2 contracts. And for anybody out there, free consulting, everybody's gonna say they know this, but it's really in the details here. Anyway, what I want them to come away with this is, in this space, there's a lot of nuance and there's a lot of gray area that you need to make sure that you're tightening up. And if you're not dealing with an expert, like you should be, right? Because this is a really, it is a space that has a lot of repercussions if you get it wrong. Mm-hmm. And that's really important. And so anyway, what we do is we review 2 contracts. The plan document, obviously, right? Understand the discretion and authority of the plan sponsor within that document. That sounds a little counterintuitive, but sometimes you work with certain TPAs that might be owned by certain BUCAs that, hey, page 1 has their logo on it, not yours, right? And so you're working within their plan document structure, and you need to make sure that, not often are they acting as fiduciary, but make sure that you understand that dynamic. That's 1. Number 2 is understanding how you're accessing your primary discount. That can be in the form of a direct PPO contract, a joinder agreement with a TPA. That could be an ASO agreement. It could be an ASA agreement, like an administrative services agreement with like a UMR or Meritain, et cetera, right? So understanding what parameters are in place that might have limitations or restrictions. Also, a couple of red flags that you're going to want to be at the lookout for. So yes, you might be able to put plan, everybody likes to talk about plan language, and I'm not minimizing it, but plan language it could be legal from an ERISA perspective, but that doesn't mean that you're compliant with your contract that you signed with the network, right? So you need to make sure that's permissive within that. More often than not, I think this is the common misconception, is that they hear from either the TPA or the network themselves, oh, you can't do that, right? Okay, well, let's point to the language that says that we can't or that we can, or figure that out, right? And from there, what we're doing is making an assessment of how do we move forward and what's the right plan structure, plan design, and then great plan language built around that so that your plan is as black and white as possible as far as the defined benefit for outpatient dialysis services. Well,
that's, I think obviously your name comes from the specialty care management. You're talking about being a specialist in a particular field, which I loved. You can go to a BUCA and they kind of do all things, and, there's nothing necessarily wrong with that model. It's got its merits for certain reasons, but for all intents and purposes, they're kind of a generalist for everything. You're going to them as a one-stop shop for all of these parts. But then as you start getting further along the spectrum of self-funding and you start looking at what pieces can I carve out, who are the real, true, best-in-class TPAs and PBMs, and now you're talking about a best-in-class solution for a specific, this is really for a specific treatment methodology, right? A specific condition. And so you're sort of articulating that the value proposition, right, is we are experts in this very narrowly defined space, a space that this is a big problem, is very prevalent, very costly. Let us be your experts for that. So I think one thing you mentioned to me as we were sort of chatting beforehand is, are you guys almost carving out your own plan document or carving out language that's specifically written in for this, right? Is that correct? Did I understand that correctly?
Yeah, you did. So we can do it a couple of different ways. And that's why I talked about understanding like kind of the correct path to successful implementation, right? And one of the things, I'd be remiss if I didn't say this, not trying to plug us, but like we've had 100% retention of our discounts since 2002. It's 20 years of, hey, that's the final claim payment, right? That's important when you're talking about a risk management strategy. So you want to make sure that, to your point with a generalist, yes, could the outcome be the same or I don't know, even better, not often, but let's say even better, to be contrarian, with a generalist? Sometimes, maybe. But we're creating a normalization or a leveling effect. So and granting you predictability, and that's a really important piece. But I said this to you earlier. If you have surgery and you have the greatest general surgeon in the world, but you need a thoracic surgeon, you should probably go to the thoracic surgeon. You shouldn't go to the generalist. He or she may do just as good of a job on you as a sample size of one. You might have the same outcome. Again, maybe even a better outcome, right? But across the aggregate of all of that person's patients, there's going to be better and more predictable outcomes with the specialist.
Yep.
And that's how you want to deal with this. It happens to be something that deserves that type of attention because of the high dollar, high volatility nature of the risk.
Yeah, and I think and I like the idea that you're being a contrarian, and we'll talk about. Is there not an appropriate group, or why would we not do this, right? I mean, I like to challenge people with that because, you want to make sure that there is at least some understanding and it's not the appropriate fit for everybody. You can't just assume that's the case. But before we do that, let's kind of talk about what is the appropriate type of group. We've talked about maybe a size segment, that small to mid-market. Presuming, right, self-funded, they have to be a self-funded group.
Yeah, we work in the self-funded space.
Okay, yep. So what is that profile, right? Or like, what is the most likely group that's going to engage with you in order to implement this solution?
Yeah, so you asked about the carve-out piece, and I'll work that into this answer. So understanding, we are, there's kind of a legal assessment and there's administrative structure, and those two components really are the ultimate drivers of how you need to implement. So we built capability around two. In some instances, you can come in and just straight up amend the plan. You asked about that. Just amend. It can be amendment number 4 to Joe's Machine Shop's employee benefit plan, right? And or if the administrative structure, maybe not the contractual perspective, but from an administrative structure, so that contract, the ASA or whatever, maybe that component says, hey, listen, we're just in a place. I'll pick on, just like on a BUCA type entity, like a UMR or something like that, where it's like, hey, we have to carve it out completely, not only from the plan, but also administratively, right? And so, yes, we have capability to be able to do that, just a straight amendment or as a separate plan document altogether. We even have instances where we create a separate ERISA plan as well, which is a different ballgame. But whatever we can put on the table that's going to ultimately provide the plan sponsor their protection. Mm-hmm. So that's a really key part of that.
Well, and outside of size segment and perhaps obviously being self-funded, do you tend to get more involved with groups already got dialysis and knows it's a problem that need to address, or is it like, are there some proactive groups that are coming to you as well that just, we know we need a solution because we heard in the marketplace this is an issue? Yeah,
we have a healthy dose of both. More often than not, we're coming in as firefighters, right? So house is on fire, we need to come in and put it out, right? The nice thing about our program and the program in general, and this is not just specialty care management. This can be done regardless of who you're using. They can always be done mid-treatment, mid-plan year. Like there's no reason to do it on anniversary necessarily, et cetera. And again, just because somebody's active on it doesn't mean that you can't and with SCM at least, there's no disruption in care. There's no, hey, you need to move centers or any of that kind of fun stuff, right?
Okay, so you can do it midstream.
Absolutely.
Okay, cool.
Yeah, and I'd say more often than not, that's how we do get brought in when we work with the broker consultant market or even the stop loss market, even though that tends to be on anniversary. But regardless, so that's how we get brought in more frequently than not. But then what happens is we build up relationships with producers, whether that be a broker shop, or whether that be a general agent, or that be a stop loss carrier. Mm-hmm. What they ultimately do is they say, hey, this has value. We can even financial value up front as a proactive measure. Let's get them started now before they ever hit. And so that's a growing way of thinking about this. I think there's a lot more folks, probably a lot of people in this audience, that are very proactive in the way that they manage risk. Mm-hmm. And this is one of those things that they can add in. With us, there's no cost to doing that. So there's no like implementation fees, and there's no PEPMs associated with it or anything like that. So it's truly at no cost outside of a contract to a plan to bring our solution in. And very often, depends on the carrier, depends on their assessment of the risk, but you can even get like premium credits for proactively managing this risk type. Because to your point earlier, right? If you have a normal risk range of 350 to 500K on paid claims on this, but those $800 million paid claims are lurking out there. Mm-hmm. With us, if hey, we have $100,000 corridor here, like we can get basically 180 to 280. We know that's going to be the risk. So if that future risk hits, we have some predictability of what that will look like. They can give that in the form of premium credit as well.
And is there a group that maybe is not a fit for this? I mean, maybe it's just the size, obviously fully insured's out of the equation, but is there anybody that you're just like, either you can't underwrite this, or maybe just this, you're coming at this for the wrong reasons? Tell me about a group that maybe you have to turn down, or maybe just you can't get there on.
So there's not a profile from hey, you use this network or you use this TPA, none of that, right? And those, from that perspective, we're agnostic, and it's really truly goes back to that assessment of the contracts, the plan document, and the network access, for lack of a better term, right? So where we look for red flags in those things. And so where we will decline to work with a specific plan sponsor is if there are terms within those agreements that we say, oh, okay, I can give this again to my 9-year-old. I can show him that in this, restrictions and limitations clause, it says sole and exclusive, right? And if I tell him exactly what that means, or at 9, he knows what that means, and he can say, oh, okay, so nobody else can work with them. It's only Cigna or whoever it might be, right? So that's the profile. Really, it's a case-to-case assessment, but there are plans out there that have contractually sort of limited themselves, mostly unknowingly, right?
I was going to say, they probably aren't aware that
they have no idea that they have. Basically, they've taken all the good parts of self-funding and what ERISA gives them and signed it away and said, hey, we can do whatever we want it usually says something to this effect. We can do whatever we want with the plan document, but XYZ enterprise is the sole and exclusive provider of all cost containment services and or blah, 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 unless it's written and agreed to and signed, and they're never going to do that. So you've effectively signed away your ability to implement solution, dialysis, specialty drugs, whatever it might be, gene therapy. You can't do any of that stuff without that enterprise saying, yes, we agree that you can do that.
And then, of course, it's not going to be in their best interest to agree to that. So that, like you said, they're never going to agree to that.
Nobody wants to reduce their revenue.
Yeah, no, that's not a very fun thing for anybody. So I want to go back to something you mentioned. We talked about carve out, and you brought it up obviously as well. Was there I feel like there was a court case or something relevant to the carve out particular. Can you help me? I'm trying to retrace my memory, and I can't remember what it was.
Yeah, there were two. Okay. Right? So, and they're contradictory, which makes it even more difficult. Okay. So there was the 6th Circuit and the 9th Circuit. The one that that we have that's going around with 6th Circuit. There was a lot of different intricacies to that. I won't get into all the technicalities, but I think the two main components of that, and this goes back to the whole expert thing really, is two things. There's been some misconception out there, and some people putting out there that, hey, it has to do with multiple of Medicare and pricing to multiple of Medicare. First of all, I like to apply common sense to things. Let's apply this. There's an entire RBP world out there that's doing that, right? They're saying, hey, everything's at 150 of Medicare, whatever, you pick the number. that's not what it was about. It was really about defining arbitrary, and that was their word, arbitrary payments, right?
Okay.
And defining what arbitrary payments means. A multiple of Medicare, if you will, or a factor paid over and above a Medicare rate, that in and of itself actually reduces risk. And I'll tell you why. Medicare tables are public information, right? Like it's something that you can go find. It's easily defended, and it's really simple to go out and say, okay, so in Birmingham, Alabama, for hemodialysis, the reimbursable bundled payment for hemodialysis is X. And if you are, applying a factor of like 1.25 or 125% of Medicare to that, that's not arbitrary, not in any way, shape, or form. But if you don't build the right plan language around that, and you just say, hey, it's 145. So you work with somebody who builds plan documents, and they cover you for outpatient dialysis, or it'll just say dialysis too. But if you cover it for dialysis and say, hey, we just pay it at 140%, there can be some gray area there. Everything in the legal world has gray area, but you want to make it as black and white as possible, right? And that's a really important piece.
So they define it as arbitrary, and the argument is even if maybe that's a common multiple of Medicare, that it's still arbitrary because how did we land on that percentage, or what was the argument?
Well, it's not even that. It can be. There's a lot of different ways that it can be arbitrary. So a lot of people are using like a UCR approach, right? And they say, okay, well, we have a great usual and customary definition. That's probably not true, but lots of them think that they do. And so they use that as the baseline for a payment. That's easy to say is arbitrary because you have to defend, hey, how'd you come up with the number, the 1.0, if you will, before you apply some factor to it. So it was really about arbitrary payments. And the second component to that was discrimination. And discriminatory plan document language being discriminatory is a key thing. Again, really technical and nuancy, but suffice to say, you don't want to have any correlation to like Medicare, for example. And that was the key thing. So that's where Medicare really came up was, hey, this plan language correlated directly to Medicare or the Medicare coordination of benefits period or something to that effect. So while plan language can be, again, technically legal, that doesn't mean it's compliant and it's non-discriminatory or it's not defining your benefit as in an arbitrary way. So you want to make sure that you're working with somebody who's going to, provide a thorough review analysis and really provide a defined benefit that is going to create predictability, and not only in the first dollar payment, but in the outcome of hey, at the end of the day, that was the final payment.
And in what way could it be discriminatory? I want to make sure I understand that.
Sure.
Discriminatory. What was being discriminated against in that argument?
So, over the years, there's been a lot of different. So sometimes people can just as simple as say, hey, you can do it as a diagnosis rather than a procedure type, right? So we see that with some regularity, more so a few years ago. But you'd say, hey, for members with ESRD, this, that, and the other, you're defining a benefit by diagnoses. Obviously, that's discriminatory. There's others out there that say, hey, it's more loose than that. Or you could say, hey, listen, you are required to enroll in Medicare. Some people say that. You can't require somebody to enroll in Medicare. That's discriminatory. You're treating the people within the plan that have access to Medicare differently than the rest of the population. And then third, and a little bit like one step removed from that, is some folks out there will correlate to that coordination of benefits period, saying, hey, we'll pay you at X for the first like 40 or 42 services, which happens to correlate to 90-day waiting period to enroll and be enrolled in Medicare as a full-fledged Medicare recipient for hemodialysis members. However, and then after 42, we're going to pay, or 40 or whatever number they use, we're going to pay at a different rate. That again, I'm not here to be a legal pundit, but that can be reviewed as, hey, look, that's direct correlation to the Medicare secondary payer coordination of benefits period. And so it's good intentioned, right? Mm-hmm. The intention of the plan sponsor at that point is, hey, I want to cover my member the best I can. And in order to do that, I'm going to make sure that we're paying differently for those things. So there are a lot of other ways that it can happen too. I don't want to take up too much airtime, but there are a lot of ways that you can be discriminatory in perfectly legal plan document language.
Okay. Man, and I'm not even the closest thing to a legal scholar at all, but you realize, you mentioned nuance earlier, but there's so much intricacy of the way the language is weaved, right? And who's actually weaving the language and who's establishing the precedent, which I guess obviously speaks volumes to why you'd want to work with somebody that literally specializes in exactly that. The one thing that we haven't really touched on that, we talk about dialysis as, a long-term, chronic treatment methodology that may eventually lead to Medicare taking over after that 30 to 33 month period. What about the other side of that? Because I know there's a transplant side of this as well, which is actually, it sounds like that's actually the more favorable outcome. Is that correct? Is somebody getting a kidney transplant instead?
Oh yeah.
Okay.
From a purely human patient perspective, that's the ideal outcome, right?
Yeah.
So, and we will help coordinate that. And I think that's a really important part, again, of the risk management strategy. So not only is that what's better for your employee and their health, but also for your bottom line, right? So an average, somebody's going to be waiting. This is, kind of back of the napkin stuff, but the average wait time on the kidney transplant list for a non-live donor is like 20 months.
Okay.
So, very often if they're not having that conversation up front, you're going to exhaust that 33-month period that we talked about. So you're going to end up paying the maximum for that time before they ever end up transplanting. Or, you're going to have the first, in a good scenario, the first 20 months, let's say, of paying at, these really high dollar claims, even if it's us involved. I mean, it's still a lot of money, right? No matter who you're paying and what vendor solution or how you're doing it, it's still a lot of money. It's a lot less money with some solution than other, but it's still a lot. And so rather than paying at that high level for 20 months, if you are coordinating the transplant part of it early enough and having that conversation with your membership, you can start that earlier so that the 20 months then maybe only happens and you only end up with a 15-month exposure because they get transplanted 5 months earlier because you've started that conversation, got them on the list, all that fun stuff. We help coordinate that typically with a transplant case manager that's in place. We're not doing that direct often. Sometimes we are, but for the most part, we're dealing with somebody to do that. Same thing on the back end with Medicare, making sure that they have that the transition to Medicare as primary is going to happen. That transition is smooth and seamless, and the financials go the right way on that.
Well, and speaking of financials, right, like what is the relative calculation, right, of the continuance of dialysis versus the cost of a transplant? What's an average transplant cost?
The average, that's a good question.
Okay.
I'm not sure.
I know it's not necessarily your space, right?
Well, it is. So but I would say that this kidney transplants are becoming so sort of commonplace, and the technology as such that they've become way more predictable, right?
Okay.
So they're less variable. And so they don't represent as big of a risk. And certainly from a dollar perspective, I don't know, you've seen the lasers on those things. So let's say they have a laser and they have a $500,000 laser on an individual. And typically the breakout on that you'll see is, like 350 of it's on the actual dialysis as a procedure. And then based on this expected transplant date, it's like $150,000 on that. Those are the numbers I see when I look at, policies, not, kind of one step removed from it. Mm-hmm. But that's, those are the kind of things I see as far as on the stop loss side.
Yeah, I just think it's fascinating, right? Because it's one of the few, that I know of, that conditions where if there is a transplant, that's actually the, kind of more desirable outcome, and that leads to a better prognosis long term. Because I think you mentioned earlier, right? You only need one kidney, and you can live with one kidney, and that's why I guess family members end up donating quite a bit. And I just find the whole thing fascinating because it's not something I've dealt with personally, but I know it's a kind of a big issue that a lot of people have to deal with. So looking at maybe your Craig's crystal ball, right? Like I know you've been in the space for a long period of time. Where do you see us moving here? Like, is it a combination continuance of the public and private sector dynamic, or what do you think some more solutions that'll be coming forth, particularly for this space?
Yeah, that's a great question. So I think that the issues that we're witnessing and that we're living through right now are only going to continue to compound, right? I think that there's going to be a huge push. And there already is. I think this dynamic's already taking place, but there's a huge push to get proactive on these things. And I think that's a really key component. as the consolidation and the general market risk becomes greater on our side, on the private insurance side, as that becomes greater, there's going to be more and more pressure for groups and their representatives to proactively manage, catastrophic risk, and outpatient dialysis being one of them. And so, I guess the crystal ball is saying, and I've kind of hitched my wagon to that, where I think predictable risk, like understanding that this risk exists, it's becoming a greater prevalence, and that the cost is going up, and trying to figure out, how do I, as an employer or as a representation, how do I combat that market dynamic in the most effective, efficient, and appropriate way? Because I think the appropriateness of it is a really key part. So like, we're looking at appropriate payments for these things, and part of that is through the predictable nature of it. So for us, and then building capability around that. You mentioned, whether it's, this capability of just, hey, we work with, XYZ TPA, and we're there in a very traditional vendor setting, and we just, work with them sort of internally, so to speak, or we do a full carve out. We have an awesome program called Dialysis Plus, which is a full carve out where we do all the administration on it. We, claims are funded through us. We adjudicate the claims, all the reporting and routing and everything. Everything is done, through us. That's kind of where I see the future going, because so much of the market is unable to, within certain structures, put solution like this in place. And so that's where I think that the really big next thing is. The next thing is, well, I want to do these things. I have the desire, and I probably have the need to do it, and I need to start doing it proactively. But I'm either comfortable, or for whatever reason, I'm set in this particular dynamic, right? With this TPA and this network, and for whatever reason, I have to have those things, even though we know that might not be true. Can you build a solution that can fit in that, right? So to be, again, cliche, do you have a square peg for the square hole and a round peg for the round hole? And no, hey, if you need a triangle peg, I don't have one, right?
Yeah. Well, and so if somebody wants to kind of bring this to the fold, right? Is it typically through the broker channel that your solution's being brought to the table? Is that your primary sort of distributor of the solution, or is it you going direct to employers, or how does somebody reach out to you and to explore this as a possibility?
So I'm all about, and specialty care as our whole, we're all about alignment of incentives, right? So I want to make sure that we are aligned and everybody's kind of pushing in the same direction. Mm-hmm. So for me, one of the big things that we've done here is we've aligned ourselves very much with that broker, and their representatives of that broker advisor market. And because I think that what they're there to do is be on the lookout and be the best steward of their plan, right? So this is about preservation of assets and reallocation of funds. Really, at the end of the day, that's what it's about, mm-hmm. right? We want to preserve the assets of the employer so that they can be properly reallocated, whether that's continuing to be part of the health and welfare fund, whether that's redistributing and giving raises, or whether that's, the owner of a small, company goes and buys a new boat, whatever they want to do with it, right? It doesn't matter. It's their money, and they don't have to give it to DaVita or mm-hmm. whoever, right? Mm-hmm. So I think that's a really key part of that.
Well, I think it just, one of the sort of overarching themes is a proper alignment of the incentives, right? For everybody, and especially the member, the person that has to sit there and stay hooked up to a machine for 4 hours a day and 4 days a week or whatever, exactly, something of that nature, is not, are they being steered one direction, or are they being pushed over here? Or are they just arbitrarily picking this provider because they don't know any better? It's having a little bit more conscientiousness to the whole process to make sure that we're all, like you said, rowing in the same direction. I think that's an important thing to consider.
Yeah.
So, reaching out to you, what's the best way to get a hold of you guys? Is it to go to your website, find you on LinkedIn? How does one reach out to Craig and Specialty Care Management?
Yeah, I think either one of those, right? So we have a healthy, growing LinkedIn following, which is cool. And that's been an awesome dynamic in the past year and a half for us. And then certainly the website, obviously coming to, we have a contact page, or just, you find us all on the people part of LinkedIn, and just shoot anybody a DM, and we're there. We talked about, you asked me about the broker advisor market, and the reason that we do that rather than like a TPA as a direct sale, mm-hmm. we certainly do those as well. But I think the really important part is for us on the broker advisor side, right, is that alignment of incentives, but it's also to be able to empower the broker or the group directly. So we don't often go direct to the group, but be able to empower that broker to build the solution that ultimately they want, because that's really, at the end of the day, that's why they're self-funded, right? They are self-funded to control risk and cost. And that is what we want to be there. So that's really why we work through the broker market, because that's their main job. That's what they're doing.
Yeah. And this, I always say that I don't envy the position the brokers are in, because they have so much that they need to understand. And that's why having somebody that, like you or like specialty care management, somebody that you trust, right? That if I know this is an issue for this particular group, or this is a unique solution that's out there to address a particular area of need, that's really important, because they don't have any more hours in the day than anybody else has, but they're supposed to sort of triage everything that comes into them and present these solutions. So I imagine, you're probably are you doing some in person? Are you being brought to the fold to talk to the employer directly once a broker is assessed what this might be? Are you coming in and maybe presenting that final messaging and story to the group?
Sometimes it really depends on the relationship that the broker consultant has with the group, and quite frankly, the size sometimes of the group. Some CEOs or owners or whomever, CFOs, they might want to be, hey, let me hear from these guys, right? I want to hear how authentic they are. How much integrity do they actually have? What are we bringing to the table? I want to see that. I want to feel that. I want to hear that, right? Yeah. Very often we work with shops, we work with brokers and their entire, kind of force. And they realize sort of after one or two wins, hey, I get this. I understand the power. I understand the impact financially. I understand the benefit to the membership. I understand all this stuff. And so then we kind of become ingrained, right? Yeah. It just becomes part of what they do. So they almost become, they're not our sales force, but they say, hey, listen, we should do this because it's the right thing to do, and we vetted the right partner. And so that's, for me, that's the ideal relationship, right? Because then all of a sudden I'm getting, referral emails.
Yeah, and I think anybody would welcome that, as like over time, if you've established yourself and you have a proven track record that, there's a continuance, right? There's a sort of a snowball effect from that. So, just any final thoughts you want to leave folks with to wrap it up, or one thing you want to, make sure that they remember if they've listened all the way through here to this point. Hopefully people have stuck it out, but what would be the one thing that you'd want to say to the folks that are listening out there? Yeah,
I think, the one thing is that risk management is complex, and specifically in the outpatient dialysis market, there's a lot that's happening. And if you're not somebody who's managing and monitoring that, and all aspects of it, day to day, right? And that's really what you do. If you're not doing that and you're not working with somebody that's doing that, you should at least give yourself the opportunity to speak with somebody who is that, right? Yeah. Because you're doing yourself and your client base a disservice if you're not working with the best in class. It doesn't mean what you're doing was wrong. And I think that's the biggest apprehension sometimes on the consultant side, is they go, oh man, I don't want them to think what we've been doing for 3 years is terrible. Yeah. And again, our job is to empower that individual, that broker, that consultant. And so it's collaborative. It's all very consultative. And so you need to be at least doing yourself the justice of speaking with somebody like me, or like somebody from specialty care management who is an expert in this and can tell you how you can further optimize, whatever you're doing.
Well, that's what it's all about, right? You became self-funded for a reason. And, I think if you stay stagnant and assume like, oh, you're going to have a better outcome over time if you just keep doing the same thing, I mean, that's the definition of insanity. So I really appreciate that. Really appreciate you coming on, Craig. Again, thanks for traveling all this way, man. And hopefully on your trip back is a little bit smoother on the plane. But thanks again, Craig. And I look forward to speaking to you again soon.
Thanks for having me, man. I'm not only am I here, I'm a huge fan, and everybody at SCM is a huge fan. So like, people freaked out when they found out I was coming down to do this. They're like, oh my God, you're going to be on there with Spencer.
That's funny.
Yeah.
So, well, if I'm the, stop loss,
you're a celebrity.
Okay. Probably not, man.
But you really are.
Yeah. But in the very, very, very tiny world that we exist in, then I'll take that, man. But thanks again, Craig. And
thank you.
Looking forward to having some drinks here in a sec.
All right, man.
All right. See ya.